Welcome to the deep dive. You've shared your MSRA notes with us, which is fantastic, and we're here to really help you nail that revision.
Exactly. We're going to focus in on one of those high-yield topics today.
And that is phaeochromocytoma. Bit of a tongue twister.
Yeah. Often just called Pheo. It might seem rare, but honestly, understanding it is vital for the MSRA.
Look.
So we're planning to cover everything, the whole picture.
Great. So let's start right there. What exactly is a phaeochromocytoma? Lay it out for us.
Okay, so basically, it's a rare tumor. It grows from chromaffin cells.
Mm.
These are mainly in the adrenal medulla, the inner bit of the adrenal gland.
Right, on top of the kidneys.
That's it. But they can also appear in other places called paraganglia. Now, the really crucial part is that these tumors churn out excessive catecholamines.
Adrenaline and noradrenaline?
Primarily those, yes. And it's this flood of hormones that causes the biggest issue: hypertension, high blood pressure.
So it's like the body's stress response system is just stuck in overdrive.
That's a pretty good analogy, actually. Now, most are sporadic, meaning they just happen, and they're benign, not cancerous. But, and this is important, up to maybe 40% can be linked to inherited genetics.
40%, that's quite high.
It is. And there's also this thing called the rule of tens. That's a bit old now, but still a useful rough guide. Roughly 10% are bilateral, so on both adrenals.
Okay.
10% are malignant, cancerous.
Right.
And around 10% are extra adrenals, meaning they grow outside the adrenal gland itself in those paraganglia.
Right.
Sometimes we find them because someone has symptoms. Other times it's an incidentaloma found by accident on a scan for something else. Or through screening, people we know are at risk genetically.
And if it's not treated...
Well, that's where it gets serious.
Yeah.
The high catecholamine levels can cause life-threatening problems: severe hypertension, arrhythmias, heart rhythm issues.
Wow. Okay. And the name itself. Phaeochromocytoma.
Yes. It literally comes from the Greek words for dusky color, because the cells stain a dark color when you treat them with chromium salts. Bit of trivia for you there.
Always good for memory hooks. So you mentioned genetics. What's the usual cause or etiology?
Well, for most people, maybe 70% seems to be sporadic, no clear inherited cause. But like I said, that leaves a big chunk, around 30%, that are linked to specific inherited genetic mutations.
And these are the ones we really need to know for the exam.
Definitely. The big three syndromes to remember are MEN2, that's multiple endocrine neoplasia type 2. Then there's VHL syndrome von Hippel-Lindau. And finally, NF1 neurofibromatosis type 1.
Right. So MEN2, VHL, NF1. If a question mentions a young patient with a Pheo, should those immediately come to mind?
Absolutely. Spot on. A younger patient presenting, that's a big red flag for one of these underlying genetic conditions. Definitely exam worthy.
Okay. So beyond the genetic link, who is actually at higher risk? Are there other specific risk factors?
The main risk factor is that family history, or having a known mutation for MEN2, VHL, NF1, or some others like SDH gene mutations. But what's also incredibly important, maybe even more so clinically day-to-day, are the triggers for a phaeochromocytoma crisis.
A crisis. What happens then?
That's when you get a massive surge of catecholamines. It can cause incredibly severe hypertension, maybe organ damage. It's a medical emergency.
Okay, crucial to know. What sort of things can trigger one?
There's quite a list, actually. Things like induction of anesthesia, really important preoperatively. So drugs are culprits too. Opiates, some dopamine antagonists.
Like anti-sickness meds?
Some of them, yes.
Oh.
Also common decongestants with pseudoephedrine in them. Think about your cold and flu remedies.
Right.
Then there are drugs that mess with catecholamine reuptake. Tricyclic antidepressants are a classic example, and cocaine too. Even things like X-ray contrast dye used in scans, and the physical stress of pregnancy or childbirth.
That's a lot to keep in mind. Any simple way to try and remember those triggers?
Let's see, maybe an acronym. How about thinking? AODDMXP, something like anesthesia, opiates, dopamine blockers, decongestants, MAOIs, well, drugs affecting reuptake like TCAs, X-ray contrast, pregnancy.
AODDMXP. Okay, that might help lodge it in the memory banks. Thanks.
Hope so. It's just a way to structure it.
So we know where they come from, the risks, what's actually happening inside the body, the pathophysiology.
It all comes back to those chromaffin cells. In a Pheo, these cells basically go rogue. They stop responding to normal controls and just pump out huge amounts of adrenaline and noradrenaline.
Uncontrolled release.
Exactly. And these hormones then circulate and hit receptors all over the body. That's what affects the high blood pressure, either coming in waves or just staying high, and all the other varied symptoms people can get.
Right, makes sense. Now, you mentioned symptoms can be varied. Does that make diagnosis tricky? What else could it be? The differential diagnoses?
Oh, definitely. Diagnosis can be a real challenge because the symptoms overlap with so many other conditions. Things like just standard essential hypertension, anxiety disorders, panic attacks are very common mimics.
Because of the palpitations and anxiety feeling.
Precisely. Also, hyperthyroidism and overactive thyroid can look similar. And of course, other causes of secondary hypertension.
So if someone has those symptoms, what steers you towards thinking Pheo?
Well, the first big clue usually comes from the biochemistry. Finding those high levels of metanephrines or catecholamines or VMA in a 24-hour urine collection, that's a major pointer.
Okay, the tests.
Then you look at the bigger picture. Is there a family history suggesting MN, VHL, or NF1? Are there tumors in both adrenal glands? That points towards men. Does the patient have signs of NF1 like the cafe au lait spots or neurofibromas?
Right, linking it back to those syndromes.
Exactly. Or signs associated with VHL, like specific brain or kidney tumors. And you have to keep other things in mind too, like carcinoid tumors, alcohol withdrawal, just really labile blood pressure, drug abuse. Even rarely, someone making themselves seem like they have it. Factitious Pheo.
A real diagnostic puzzle sometimes. So how common are these tumors overall? What's the epidemiology look like?
They are definitely rare. The incidence is estimated somewhere around, say, 0.8 to maybe 2.3 cases per 100,000 people per year. So not common at all.
Tiny number.
Yeah. But interestingly, if someone has an adrenal instantinoma, a lump found by chance on a scan, Pheo accounts for a fair few of those, maybe up to 5–6% in some series, though your notes mentioned up to 60% prevalence among them, which seems very high, maybe referring to a specific high-risk population. Let's stick with the general rarity for now.
Okay. Rare overall, but something to check for in incidentalomas, benign or malignant.
Mostly benign, but a significant minority, maybe around 10–25% depending on the source, can be malignant. It affects men and women pretty equally.
And age.
Usually diagnosed in the 3rd to 5th decades, so people in their 30s, 40s, 50s. But remember, the hereditary cases often show up much younger.
Right, especially in kids.
Exactly. In children diagnosed, up to 70% might have an underlying hereditary cause. And the link with hypertension is obviously very strong. But here's a really stark statistic. Some studies suggest around 50% are only diagnosed at autopsy.
Wow, half of them are missed.
It really underlines the diagnostic difficulty, doesn't it? And again, reinforcing the genetics, maybe up to 40%, potentially even higher in some groups, are linked to those mutations. MEN2, VHL, NF1, SDH genes.
Okay, that autopsy statistic really hammers home the need to think about it. So if someone...
Definitely not. And always, always ask about family history, digging for MN2A, 2B, VHL, SDH mutations, NF1, because up to 40% have that hereditary link. The symptoms themselves are often intermittent, variable in frequency and severity.
And on examination.
You'd expect to find hypertension. Sometimes, weirdly, postural hypotension, their BP drops when they stand up. You might see hypertensive retinopathy, damage to the back of the eye. And look for those physical signs of syndromes. Neurofibromas, cafe au lait spots for NF1.
So the message is, think Pheo with suspicious symptoms, especially the triad, plus resistant hypertension or irrelevant family history.
That's the bottom line, especially hypertension that's hard to control.
Is there a quick way to remember those key features? You mentioned the triad.
Yeah, the triad is good. Hypertension, headache, palpitations, or that mnemonic PHE for Pheo can work too. Palpitations, headache, excessive sweating. Just remember, hypertension is the most common feature overall, but that PHE trio is very suggestive of the catecholamine excess.
PHE, got it. Okay, so suspicion is high. What investigations do we actually do to confirm it?
Right, investigations. This starts with the biochemical tests. They're the cornerstone. The best single test is usually the 24-hour urine collection for metanephrines.
Metanephrines, not catecholamines directly.
Metanephrines are the breakdown products, and measuring them tends to be more reliable and sensitive, around 97% sensitivity. It's largely replaced measuring the parent catecholamines in urine these days.
Okay, 24-hour urine metanephrines. What about blood tests?
Yes, you can also measure plasma catecholamines and plasma metanephrines. Measuring plasma-free metanephrines is often preferred if available. It's also very sensitive.
And that clonidine suppression test.
That's used more selectively. If the initial tests are maybe borderline or you suspect a false positive, clonidine normally suppresses catecholamine release from the nervous system, but not from a Pheo. So if the levels don't drop after clonidine, it supports the diagnosis.
Right, helps rule out false alarms. So once the biochemistry confirms excess catecholamines, you need to find the tumor.
Exactly. Step 2 is localization with imaging. Usually you start with a CT scan of the abdomen and pelvis. It's pretty good, picks up most adrenal tumors over a centimeter.
And if the CT is negative or you suspect it's outside the adrenals?
Then MRI can be useful,
Yeah.
especially for looking for metastatic spread or if CT contrast is an issue.
Hmm.
If both CT and MRI are negative, but, biochemically there's a Pheo somewhere, then you move to functional imaging.
Like the MIBG scan.
Precisely. MIBG uses a radioactive tracer, iodine-labeled meteodobenzyl-guanidine, which gets taken up specifically by chromaffin tissue, so it can light up a tumor that anatomical scans missed.
Clever. Any others?
There's also pentetriotide scanning, sometimes called octreoscan. It binds to somatostatin receptors, which some Pheos have. It's generally less sensitive than MBG, but might pick up tumors imaging misses. CAT scanning is also emerging as a useful tool, especially certain types of PET scans.
And genetic testing.
Absolutely essential. Current guidelines recommend considering genetic testing for all patients with pheo or paraganglioma. The specific genes tested might depend on tumor location, age, family history, etc.
And after surgery.
After surgery, histology is crucial. They examine the tumor under the microscope. Pathologists might use scoring systems, like the PASA score, to try and predict if a tumor is more likely to behave malignantly, although differentiating benign from malignant can still be tough just on appearance.
Okay, quite a workup. So tests confirm it, imaging finds it. How do we manage it?
The definitive treatment is almost always surgical resection removing the tumor. But, and this is absolutely critical, you must stabilize the patient medically before surgery.
Because of the risk of hypertensive crisis during the operation?
Exactly. You need to block the effects of those catecholamines first. This means starting alpha blockers. Phenoxybenzamine is the classic one, usually started 10-14 days before surgery.
Alpha blockade first.
Always. To control blood pressure and allow the patient's blood volume to expand, they're often quite volume depleted. Then, once alpha blockade is established, you add beta blockers, like propranolol.
To control the heart rate.
Yes, and prevent arrhythmias. If you give beta blockers first, without alpha blockade, you can get unopposed alpha receptor stimulation, which can make the hypertension disastrously worse.
So that order is vital. Alpha, then beta. AB before beta.
That's the mnemonic to remember. Once they're stable, surgery proceeds. Laparoscopic removal is common for smaller tumors, maybe less than 6 centimeters. Bigger ones might need an open operation.
And the outcome after surgery?
Usually very good if the tumor is completely removed. Hypertension often resolves. Surgical mortality is low in experienced hands, maybe less than 2–3%. Post-op, you monitor them, repeat the 24-hour urine test to ensure levels normalize.
And long-term?
Lifelong annual biochemical follow-up is generally recommended because these things can recur, sometimes years later. If blood pressure remains high, they might need ongoing medication. And of course, genetic counseling and family screening for the hereditary cases.
What about malignant cases?
That's much tougher. Management is often palliative. Radiotherapy might be used. Chemotherapy has limited effectiveness but is sometimes tried. Newer targeted therapies like sunitinib, a tyrosine kinase inhibitor, are also being used.
And managing a hypertensive crisis itself, if someone comes in really acutely unwell.
That's an emergency. You need intravenous drugs like phentolamine, an alpha blocker, or sodium nitroprusside to bring the blood pressure down rapidly and safely.
Okay. And non-crisis, just general medical management before surgery.
It's all about that careful alpha blockade, then beta blockade. Sometimes calcium channel blockers are added if needed. Volume expansion is important too, often with intravenous fluids before surgery.
You mentioned cortical-sparing surgery?
Ah, yes. In some hereditary cases, especially if bilateral tumors are likely, like in MEN2 or VHL, surgeons might try to remove just the tumor while leaving some normal adrenal cortex behind. This is to try and avoid lifelong steroid replacement therapy, but requires very careful follow-up for recurrence.
Understood. So given all that, what's the general prognosis? The outlook for patients?
Overall, it's generally good, especially if caught early and removed when benign. The 5-year survival for non-malignant pheo is excellent, over 95%.
That's reassuring.
It is. But for malignant metastatic disease, the outlook is much poorer, with 5-year survival often less than 50%. And remember, kids might have a slightly higher risk of malignancy. Most paragangliomas are benign, though. But the key message is long-term follow-up is essential for everyone because of that risk of late recurrence.
Okay, so vigilance is key even after successful treatment. Lastly, what are the main complications we need to be aware of?
The big immediate risks are all related to those hypertensive crises. So cardiovascular complications are top of the list. Dangerous arrhythmias, myocardial infarction, heart attack, heart
Or
failure.
stroke.
Stroke is definitely a major risk with that severe hypertension.
Mm.
And over the long term, chronic high blood pressure, even if less dramatic, can damage organs like the kidneys, the eyes, and then, of course, there's the risk of metastasis if the pheo turns out to be malignant.
Right. That covers a huge amount of ground.
It's a condition with lots of facets.
This has been an absolutely fantastic deep dive into phaeochromocytoma. We've covered everything from the definition and causes right through to management and complications, hopefully. Really high yield for your MSRA revision. Remember, you can always revisit this if you need a refresher.
Definitely. Getting your head around pheochromos, genetics, the symptoms, the tests, the crucial pre-op management, it's really important stuff. It might be rare, but missing it can have serious consequences.
Absolutely. And maybe a final thought for you to ponder as you revise, considering how varied pheo can present and all those potential triggers for a crisis, how could better awareness across all healthcare settings actually improve patient outcomes? Something to think about.
Good question.
For more top-notch MSRA revision resources, don't forget to check out passimsra.com and also freemsra.com. We really hope this helps, and we wish you the very best of luck with your preparation.